Okay, so hello everyone. Welcome. This is an epilepsy case study session that we're running with the AES, the American Epilepsy Society. We have a total of about 85 people who have registered for this. Glad everybody who's here is able to come. What I'd like to ask you to do is to keep this interactive. I would not want to be the only person speaking. So please, if you have something to say, unmute yourself, express your opinion. And hopefully we'll have this in a good way. You know, I'm looking now for the control.
Are you looking for the poll?
Yeah, I'm looking for the poll.
I have to switch you over to host.
And we'll do that. So I actually have controls.
Okay, go ahead.
Yeah, but it's weird. I don't actually see controls here.
Maybe at the top of your screen there's a control panel.
I have a stop share. Oh, there's my control panel. Okay, good. Let me just try to throw this in presentation mode if it'll work again. Because that's better, and then see if I can pull. Okay, good. So this is working well now. Okay, great. Alrighty, so we'll start with some case studies, and please ask questions. I'm going to have a series of questions with multiple choice for you to do as well. So here's the first case. 35-year-old man has a history of seizures starting at age 23. He has a sense of confusion for, he thinks, 30 seconds at the start of the seizure, and then he loses awareness. He loses consciousness, and it's reported, he's told by people, he stiffens and shakes arms and legs for about a minute or so, and then he's sleepy and confused afterwards, has a bad headache, occasionally bites his tongue, has occasionally wet himself. But this confusion for 30 seconds is a reliable beginning of his seizures. He started at age 23, as I said, and they first happened every few months or so. He was put on medicine pretty early, but they've gradually increased in frequency, and now they're occurring every 2 or 3 weeks in the past few months, although before January or February it was every few months or so. But the last few months have gotten much worse, every 2 or 3 weeks, with no obvious explanation. His medicine hasn't changed. He does report, however, that in times of stress, his seizures are more likely, and this man has, you know, like the rest of us, been sent home. Only like the rest of us here, he doesn't have a job anymore, so he has financial stress, and he's got kids at home, which is a problem too. He suffers. You know, in the past, it has kicked up occasionally with stress as well. He was originally given levetiracetam, doses as high as 2,000 milligrams twice daily, so 4,000 a day, but he still had seizures. Then topiramate was added gradually raising that up to 200 milligrams twice daily. And then most recently, about 3 or 4 months ago, just around the time this started kicking up, his doctor added lacosamide. And that dose was titrated 200 milligrams twice daily also. So he's on all 3 drugs now, levetiracetam, topiramate, and lacosamide at these doses. And nobody would accuse his doctor of underdosing him, I think. His history is that of some learning disability in school. He's had morbid obesity, and he has a normal neurological exam. So I'm going to start by asking you what your provisional diagnosis is, and we'll just do a poll first. So what's your provisional diagnosis? I think you should be able to see. So click on your choice, and we have focal epilepsy with focal to bilateral tonic-clonic seizures, psychogenic seizures, idiopathic generalized epilepsy, convulsive syncope, or Lennox-Gastaut syndrome. Those are the 5 choices. So we've got 50 people online so far, 28 having voted. I won't give you too much time to vote. You need to make up your minds in a few seconds, or else we'll waste a lot of time polling. So 34 of 51, 36. Okay, and I think we will stop here, 40 of 51, 41 of 51. So what we have for a result, and hopefully you can see this. Are you able to see this on the screens? Somebody say something?
No.
No.
You can't?
No.
You want me to tell you what it says?
No.
Okay. So what it shows, that this is the wonders of Zoom. It says 80% of people, so 33 out of 41, voted for focal epilepsy with focal to bilateral tonic-clonic seizures. 17% thought psychogenic. 7% thought idiopathic generalized epilepsy, and then nobody voted for convulsive syncope or Lennox-Gastaut. Or maybe if I hit share results, now maybe you can see it, right?
Yep.
Yes.
Okay, yeah, so this requires me being intelligent enough to click a box on the bottom. I apologize for not noticing that before. Yes, you can see the results. And that was with 41 people voting. Okay, so now let's move along. Here's the EEG, interrectally. So I require all patients to have an EEG when they see me for their first new visit, so at least I have something. This is what the EEG shows. Okay, this is his interrectal. And what you're going to do now is, I have to launch polls. What I want to do is choose a different poll. And I have to choose a different poll, a different question. Oh, I see, polling 2. So what does this EEG show? And your choices are left anterior temporal shock waves. I'll move it to the side. TERDA, temporal intermittent rhythmic delta activity. Rhythmic temporal theta of drowsiness. Generalized rhythmic delta. Or a focal seizure in the left temporal. So what do people think? So as we're looking at that, we had 53 voting. A couple more people have joined us. And rather 53 total, 33 voting. Make up your minds, you've got a few seconds left to decide. Okay, 42 of 53. There's still 11 cowards out there. Maybe wise people. Better not to say anything than say something wrong, right? And this is what people think. So we have 14%. 6 people said left anterior temporal sharp waves. I will move this to the side slightly. 64% said TERDA, temporal intermittent rhythmic delta. We had rhythmic temporal theta drowsiness in 7 people, some generalized rhythmic delta 0, and focal seizure left temporal. Okay, so this is a rhythmic pattern. These are not sharp waves. They're notched. It looks like it, but this would either be a rhythmic temporal theta of drowsiness or TERDA, temporal intermittent rhythmic delta. Rhythmic temporal theta of drowsiness should be 5 to 7 hertz. Some of you might argue that as we look in here, this is too slow for that. But this could be a rhythmic delta. However, in some cases, you can actually see a doublet in there, right? You can see my mouse, I hope. So that, in fact, what you may have is a subharmonic of a faster frequency in the neighborhood of 5 hertz. So the correct answer to this is rhythmic temporal theta of drowsiness. It's certainly not a seizure. It's, you can see a little evolution. It looks higher amplitude and it changes, but it's very short. It's only a few seconds. It's certainly not generalized, and it's not good enough. This sharply contoured activity is really out of a rhythm, so you don't want to call it a sharp wave. Okay, so now what do? We have a seizure. I monitored him. So hopefully this is not choppy. This is a nurse about to draw blood. This is before COVID. Is the video decent in there?
It's a bit choppy.
Good. Thank you. The nurse is doing something. And look at him. Look at his head. He had a groan, a cry. His arms are stiff. He's trembling. His legs are stiff. And now the clonic activity is better. It looks fairly symmetric. He's flexed at both arms, extended at the legs. You see both eyes blinking. Now his head's going a bit side to side in that. And he's slowing down. She's suctioning him. He's slowing down, slower, slower. whoops, stop, and it went back. What I'm going to do is just take you to the start again. So here she's wiping off his arm in preparation for drawing blood. And now look at his face. His eyes go up. And he has that moan. And the right hand and the left hand go up. And he stiffens. So what's your diagnosis? Number 1, convulsive syncope. She was about to draw blood. Number 2, focal epilepsy with focal to bilateral, psychogenic, idiopathic generalized, or Lapatas syndrome. So far, nobody's gone for idiopathic generalized epilepsy or Lapatas syndrome or convulsive syncope. We have 32 voting out of 53, 34. Let's offer some opinions. 36, 37. A couple more people get your in. You got 3 seconds to get your vote in. Say something. 33, 39. Okay. So here are the results. 2 people thought it was convulsive syncope. What argues against that? She was just wiping off his arm. She hadn't done the needle stick yet. I've never seen anybody who had convulsive syncope wiping off the arm, but I'm sure some of you in the room have. I wouldn't put it past us. Focal epilepsy with focal to bilateral tonic-clonics, most popular at 69%. 10 thought it was psychogenic, 1 thought it was IgE, and nobody thought it was Lapatas syndrome. So psychogenic, I would say this behavior, if you hear that cry at the start, you'll never hear that cry in psychogenic seizures. That initial, that's always epileptic. It's diagnostic. You can just listen to the seizure and know that it's epileptic. So really we're left, and then convulsive syncope possible. We'd have to see the EKG, but it sure doesn't have the look of convulsive syncope. He's jerked pretty long. Sometimes they can be long. Usually they don't jerk for very long. And typically they would slump first before they start. So you get a slump and then jerking. He didn't slump. His head and eyes went up, and then he started to bring his arms up tightly. And you'd expect an initial slump with convulsive syncope. So I think that's going to be very unlikely for the lack of slump and also the duration being long for that. And psychogenic, I said, from the sound you can roll it out, and also the frequency of his jerking. He was vibrating very fast, and then he slowed down, and he got really slow at the end. It was a very smooth transition in time. Psychogenic seizure patients are not good enough to do that. So let's look at his EEG. This was the EEG interictally before that we picked up. So this is the same man who we had that other interictal EEG, and now we have this. So you can see it. We're going to do a poll again. What is your diagnosis? And here are your choices. Left frontal sharp wave, generalized spike wave burst, rhythmic temporal theta drowsiness, generalized rhythmic delta, or artifact. Okay, so we have 19 people voting thus far. 91% are saying generalized spike wave burst. 88%, 86%, 84%. Okay, I'm going to end the polling now. We'll share the results so you can see it's 84% said generalized spike wave. 3 thought it was left frontal sharp waves. We have generalized delta in a couple people. A couple people thought it was artifact. Okay, so when you look at this, this is about as good as it's going to get for generalized spike and wave. In fact, at the start, you see a very nice spike and wave, maybe even polyspikes buried in here as well. You can see some polyphasic spikes very nicely in this parasagittal montage. Here is a burst for about 4 seconds, pauses for about 2.5 seconds, and then here's another burst, and it's again generalized, frontally predominant. You see it on both sides. Very nice. This is the seizure. So going into this tonic-clonic seizure, this is what we saw at first. We saw this burst of generalized spike wave. He has a burst for a second, he pauses, a burst, pauses, and then he bursts again. And look, the bursts continue, and then it evolves, and it goes up to about, you can count it, 1, 2, 3, 4, 5, 6, 7, 8, 9, about 10 hertz rhythmic alpha frequency, frontally predominant generalized alpha. So this was originally described by Frederick Gibbs, long before your parents were born, probably, long ago, as Gibbs grand mal variant, but this pattern of frontal high frequency alpha, and you can see how it evolves. And then you can see towards the middle of the page, about 60% of the way through, you start to see the muscle artifact building up. That's when the tonic muscle begins. So in fact, he was just, if he had been able to talk, he would have been spacey during this time. And that's the first page, that's the second page, and then page 3. You can see now it's generalized tonic muscle. And again, a psychogenic seizure is never going to have sustained muscle like this. So our diagnosis, I'm assuming everyone's going to get the next question correct. Diagnostic choices are number 1, idiopathic generalized epilepsy, Lennox-Gastaut, focal epilepsy, or convulsive syncope. And just put your diagnosis in. I'm going to terminate the polling now, and I'll share the results. So what you can see is 86% said generalized, idiopathic generalized, 1 said Lennox-Gastaut, 4 said focal epilepsy. This is diagnostic for idiopathic generalized epilepsy, generalized spike and polyspike and wave discharges. That's what you see in generalized epilepsy. You don't have that typically in focal epilepsy. As far as Lennox-Gastaut goes, typically they have cognitive impairment. I said he had some learning disability, but his IQ is, I didn't say his IQ was under 70. And again, you would expect to hear a mixed seizure disorder with Lennox-Gastaut. So they have tonic, atonic, maybe convulsive, maybe atypical absence. And it's certainly not convulsive syncope. Okay. So our diagnosis is idiopathic generalized epilepsy. If you recall, he started at age 23. I know it's supposed to start in the teens or childhood, but it can start in the 20s, and he's now in his mid-30s. Again, he's on levetiracetam, topiramate, and lacosamide, all 3 at very high doses. And the question is, what are you going to recommend to treat this fellow with? So here are your choices. I've got it on the slide and that. Carbamazepine, divalproex, perampanel, clobazam, or say he's failed more than 2 drugs. He's failed 3 drugs, epilepsy surgery. So people are voting. We have 34 votes in, 57 votes in, 41 of 57, 42 of 57. Okay, I'm going to end it in 2 seconds. Make your vote. Okay, so nobody voted for carbamazepine. We have 33, about 3/4 saying divalproex, 2 for perampanel, 4 for clobazam, and 7 for epilepsy surgery because he's failed 3 drugs. So the rule for epilepsy surgery is once somebody typically has failed 2 appropriate drugs in reasonable doses, you might think about it. That's generally for focal epilepsy, not for generalized. It is possible to think about surgery for these people. The operation would be an anterior corpus callosotomy. However, you'd want that person to have failed many more drugs before considering surgery. The drug of choice for this condition is divalproex, valproate. That has the highest success rate. Success rates with long-term remissions are in the neighborhood of 80 to 85%. Other drugs that have been looked at it for this kind, maybe it's a 60 to 65% long-term seizure freedom. There's no good data on clobazam. I think that's at the lower end. Perampanel has a study showing some efficacy. The odds of him being seizure-free, I don't know. Nobody's really done good studies of perampanel seizure freedom. However, if you look at the trials, long-term seizure freedom rates weren't very high. And carbamazepine actually is an option. Rarely it will provoke absence seizures, but usually not. It's pretty uncommon. If it were a woman, your choices might be different early on, but having failed 3 drugs, it would be perfectly reasonable to go to divalproex in a woman at this age too. Any comments?
Yeah, I have a question. Typically, when we're learning about localizing, lateralizing signs of seizures, we're told that a confusional state or like an aura is typically a focal onset. How typical is it to have a aura prior to a generalized seizure?
A real good question. A lot of people have some kind of a feeling, a prodrome, they know a seizure may happen that day. It's actually not incredibly rare for people to have bursts of spike waves increase tremendously right before tonic-clonic seizures, and sometimes they will perceive that as confusion, alteration of their ability to process properly. We actually have a paper coming out. It was just accepted to neurology recently. You can look for it. Sandor Beniski is the first author on the paper. I'm one of the authors on it as well, where we collected a few patients saying that this is a syndrome that's not currently in the ILE classification of absence to tonic-clonic seizure, but it's probably more common than we think. So again, it makes you think about that it's probably focal when you hear that sense, that feeling, but when it's just confusion, in my experience, confusion is not so clearly focal. Usually, when it's focal, they'll have deja vu, fear, a weird feeling, a rush, any variety of things, but it's rare for them to say they're confused. They can as well. So you're absolutely right. It's good to think about the possibility of focal with that. Is this an aura? Yeah, of sorts. It's the herald of a seizure. It's a subjective symptom that heralds a seizure, but it's an aura of a tonic-clonic seizure. And again, it represents the confusional that he can't process appropriately with generalized spike wave. Other questions, comments? Okay, I'll move to the next case. I'll have one other comment here, though. Keep in mind on your epilepsy units, these people are pretty rare coming in the door. So you're heavily biased by what you see, and what you see is a lot of focal epilepsy. You don't see too many people with idiopathic generalized epilepsy. The other thing is that non-specific findings in the intraventricular EEG, in his first intraventricular EEG, he had that rhythmic temporal theta of drowsiness, and even if it was temporal delta, a lot of people with generalized epilepsy can have these odd findings in their intraventricular EEGs as well. You really need to nail them down with a seizure or else a good spike and wave. And that's an important thing to do. And again, recording the generalized spike and wave indirectly doesn't prove that it's a generalized seizure. It's really recording the seizure that does it. One last comment, and that is there was a recent series published from the Cleveland Clinic of people who they were convinced had idiopathic generalized epilepsy. Over a third had focal features in their seizures. They had asymmetric tonic posturing or asymmetric jerking. So seeing asymmetries doesn't exclude the diagnosis of idiopathic generalized epilepsy, and you'd want to treat that way.
I do have one more question, actually.
Shoot.
So when we were discussing the seizure at the beginning, it almost like the fact that the stress kind of triggered the seizure. When I hear a story like that, I automatically think like the non-epileptic spells.
Yeah.
How common is it for stress in particular, or like a stressful event like getting your blood work done, a seizure trigger?
So, I mean, getting blood work done, I think, would be pretty rare. I think if you ask people with epilepsy, and there have been some studies, at least half of them report stress increasing the likelihood of seizures, and that their seizures are worse in times of stress. So it's not terribly helpful. I mean, the best case where I was absolutely dead wrong was a lady who I saw whose very first seizure occurred at her father's funeral as they were lowering the casket into the grave. She fell down and convulsed. And I thought if ever, and then she continued having them, and I thought if ever somebody had psychogenic seizures, that's that. And she was clearly epilepsy. And again, in a variety of studies, it's somewhat culturally dependent, but in North America, Western Europe, where their studies have been done, and in China too, for that matter, stress is still one of the most common causes of seizures. Okay, now this is just a question for localization. I'm going to show you a video. You'll watch the video.
Oh, sorry, I have a question regarding the previous case.
Yes?
I was like wondering how proper would be treating the patient with the Valprex because it's a obese patient. So.
Okay, so you have to weigh obesity versus efficacy. How many tonic-clonic seizures do you want him to have? None, right?
Yeah.
Yeah, right. And he's already failed 3 other drugs. So if you were that person, and I said, I've got a drug that has an 80, 85% chance of stopping your seizures, or I can give you something with a 60% chance. Which drug do you want?
So yeah, maybe I would prefer that.
And arguably, he's already obese. He doesn't have that much to lose. It may not make him better, and that has to be addressed separately. So you raise a really good point, actually, which actually I meant to mention, in that it's one of the side effects, but and that's why you might not necessarily rush to it as your first drug, but having failed 3, I think you want to go, because next time you could have a tonic-clonic seizure and die or have a major injury.
Okay, thank you.
That's a real good point. Okay, so look at this video and you're going to tell me the localization. Where does this come from? Whoops. Oh, yeah. Went back. Let me click on the. Okay, so here's a guy sitting on our epilepsy unit, our old one. We have a new one soon to open once the epidemic is over. He's repeating the phrase, I don't know. The feet stay in the video. Okay, let's go back to the start. He's sitting in his chair. He's watching television. His head looks down to the right. Now back up. His fingers are moving. Now his legs are moving. Watch that left hand padding. He slides down. He's got repetitive vocalizations. He's moving his legs wildly. But you see how his legs are splayed? At the hip. Annoying, this keeps jumping ahead. His legs are splayed at the hip. So it's a repetitive vocalization. What's your localization? Right temporal, left temporal, right frontal, left frontal, or is this psychogenic?
Mike, just as a reminder, there's a question in the Q&A and some comments in the chat.
Oh, I actually don't have the Q&A up. I've got to find it. Oh, okay. We've addressed that Q&A. That's
okay.
Okay, we have addressed that. I'm sorry. Okay, so we have 40 people of 55 voting. 41, 42. Get your vote in 3 seconds. It's going to end. 2, 1, end. Polling share results with 43 people voted. We have 3 right temporal lobes, 6 left temporal lobes, 16 right frontal, 17 left frontal, and 1 psychogenic. And that about says it all, right? It's not so easy, right? I mean, I guess more people thought it was frontal. We have 3/4 of you thought it was frontal, and 21% thought it was temporal, and 1 thought it was psychogenic. Okay. We're going to discuss that in a minute. What we're going to do is go to the next one, though, first. We'll look at this by contrast. Look at his feet and his hands. A lot of knee action there. Some hip, but a lot of knee and ankle. She's saying, gotta stay in the chair. He's not speaking. He's got this funny facial expression. He's holding his foot up. See this? He's not responding. She's not giving him any commands other than stay in the chair. She asks what's his name. He doesn't answer. No, he just said okay. Okay, so let's launch a new poll. Basically the same question as the last one. Where do you think this one was? Right temporal, right frontal, left frontal, or psychogenic? So we have 37 voting, 39, 40, the last one we had 43 voting. 41, I would end it in 2 seconds, make your last decision. Good. So we had 1 for right temporal, 4 for left temporal, 8 for right frontal, 24, 57% for left frontal, and 6 thought it was psychogenic. Okay. So when we think about these seizures, what did you see? You saw something strange. I must say, there's no back arching. It doesn't have the look of a psychogenic seizure. Just if you look at that behavior, this is what we would call hyperkinetic, or hypomotor would be an older term, sort of behavior. And one of the distinctions, the first fellow, it was a lot of proximal movement. It was, proximal leg movement. His legs were going, his arms were going, axial. His body was arching and rolling around. It was a lot of axial and proximal movement as he's sliding around and kicking. The second fellow, and with repetitive vocalizations, the second guy, in contrast, it was a bit more distal. You had this, bicycling. There was clearly some hip movement, but his knees were going, his feet were padding at the start, his hands were moving. It was a bit more in the way of distal. So it's a different kind of behavior, and he didn't have speech, and he was also not responsive during this. So the localization for the first one is actually a right frontal lesion, dorsolateral but fairly high, so you're getting involvement early of supplementary motor cortex, probably. And the frontal, and somewhat more posterior frontally rather than very far anterior frontal. So the farther anterior you go frontally, the more organized and complex the behavior is. The more posterior frontal, the more sort of elementary and crude it is. And this sort of axial movement, proximal jerking is pretty typical for mid to posterior frontal involvement. Obviously, you get very posterior frontal, you may just get tonic posturing if you're in immediate premotor, or direct clonic if you're in motor. So this is in front of the immediate premotor area, but it's still more posterior as opposed to towards the frontal pole. He had automatic speech, but you really couldn't say that it was right or left-sided. You could have repetitive automatic speech with either dominant or non-dominant. That's not useful. If he interacted with you in some way, if you could speak and he would actually kind of talk to you partway through it, that would suggest non-dominant. But a repetitive phrase is probably a basal ganglia release phenomenon, and this repetitive speech is not lateralizing. So we can say frontal, sort of middle front towards the back, but not so close that you're going to have tonic posturing, and you can't say for sure whether dominant or non-dominant. The second guy, more proximal, that's a little bit more of a temporal lobe behavior, organized, although very far prefrontal, you might get something like that too. And he wasn't speaking, but again, you can't be sure. And in fact, this is a left temporal, and it was a superior temporal gyrus cortical dysplasia that he had. So this was a left temporal case. And again, it's sort of the proximal versus distal, more organized. Again, he could have been a prefrontal, maybe from the temporal pole that was spreading forward to orbitofrontal and frontal to give you this behavior too. That movement may have reflected frontal spread from the temporal lobe. So that's sort of the story of those seizures. So very interesting behaviors to see. And again, the stereotypy, the pattern is not the pattern that one would see with a psychogenic seizure. So hyperkinetic, motor, prominent proximal suggests frontal, particularly mesial frontal, or again, more posterior, but not too posterior, sort of middle frontal. And more proximal, prominent distal movement suggests temporal or far prefrontal. Now, there's a paper that just hit the web this week, Epilepsy May 7, with a quantitative analysis of 37 patients in 3 clusters from a group in France. And I actually just noticed I spelled Feyerstein wrong. It's S-T-E-I-N, F-A-Y-E-R-S-T-E-I-N, not I-E-N, et al. In epilepsy, and it's just online, so you can find it. And they described 3 clusters of hyperkinetic movements. Their first cluster is asymmetric hyperkinetic movements with marked dystonia and vocalization. that they found mainly parietal. Now, I could count the number of parietal cases I've seen. Non-tumoral parietal cases in one hand, not terribly common. Somebody trying to say something? Jayu and Lee, I think you came up. Okay. So that's cluster one. Their second cluster was bilateral and symmetrical stereotype hyperkinetic movements without dystonia. So not asymmetric, but symmetric. They saw this in half of the temporal lobe seizures and 1/3 of the prefrontal. So again, this stereotype hyperkinetic, they said half the temporal lobe seizures had it. And their cluster three with strong emotionality and vocalization with bilateral and symmetrical, again, involved half of the temporal seizures and a majority of prefrontal. So take it for what it's worth, that there are certain patterns that can be described. Let's go to another case. This is the full case too, as opposed to, it's really our fourth one. This is a 31-year-old woman who had viral encephalitis at age 2. She was normal till age 2, but then had encephalitis and has had delayed development and seizures ever since. She's got 3 kinds of seizures. Sudden body stiffening, lasting 30 to 60 seconds, according to parents, with drooling, and then she's confused for half an hour afterwards. 30 minutes of confusion after a 60-second seizure. She often falls and injures herself with these seizures, and she has 5 to 8 of these per day. Seizure type 2, a brief lapse in awareness, her eyes are open, she's unresponsive, she may laugh or make other sounds, 10 to 15 seconds of duration. Parents can't count, happens a lot of times per day. They'd say less than 100, but more than 15 or 20. This has been going on for many years. And then she used to have what sounded like myoclonus, sudden jerks of a single limb or multiple limbs or a whole body, and they were very common as a little child. She's not had any for several years. She's presently on valproate 1250 twice a day, perampanel 8 milligrams nightly, lacosamide 300 twice a day, the ketogenic diet, and she'd had a VNS in it. It's off now, but the VNS was in. I just put it there so you have it. And you can see she's been treated with most drugs known to humankind, but not every single one, but she's been given phenytoin, carbamazepine, felbamate, lamotrigine, topiramate, vigabatrin, levetiracetam, zonisamide, clobazam, and as I say, the VNS. She's got moderate cognitive impairment. Estimated IQ is probably in the neighborhood of 50, but otherwise a non-focal exam. Her neuropsychology, the full-scale IQ 54, and she's lower than 1 percentile, the first percentile on every test. Her CAT scan shows right temporal encephalomalacia, and her PET scan shows right temporal hypometabolism. So that is her story. Let's take a poll. This is question 9. So what's your diagnosis? Focal epilepsy with multiple seizure types, psychogenic seizures, idiopathic generalized epilepsy, convulsive syncope, or Lennox-Gastaut? And so far, 24 have voted of 55 on. 30, we're getting up there. 33, we'll do it for a few more seconds. 39. Some people are just unwilling to vote ever. But now it's more, we're at 45. 46. A few people haven't voted. Just offer your opinions. It's anonymous. Only your program director will know. We're at 50. Okay, good. So here's where we are. We have 11 people, so about 20% said focal epilepsy. Nobody thought she's psychogenic. 2 thought idiopathic generalized, and 38 thought Lennox-Gastaut. So again, the definition of the classic criteria for Lennox-Gastaut are a mixed seizure disorder with multiple seizure types, cognitive impairment, low IQ, which she has, and the EEG characteristically, but not always, would show slow spike and wave. That spike and wave less than 2.5 hertz. And I apologize for my house phone ringing in the background. My wife insists on having a house phone, as do I, because we get a deal from Verizon. It's cheaper to have a phone than not. And we get a lot of spam calls during the day, I've learned. Okay, so 38% said Lennox-Gastaut. So she looks really like, this is a classic Lennox-Gastaut. The people who say focal, you could say, well, I've told you she has right temporal encephalomalacia, and her PET shows right temporal hypometabolism, which you would expect with encephalomalacia. Could these seizures be coming from the right temporal lobe? And the brief lapse is really a focal impaired awareness or complex partial seizure. And she's secondarily generalizing frequently. It doesn't explain the sudden jerks, but she hasn't had those. The brief lapses are only 10 to 15 seconds, kind of short for focal impaired awareness. Sound more like some sort of atypical absence, however. So it sure sounds like Lennox-Gastaut. Let's look at her seizure. Let's look at that again. See that? That brief, almost like a jerk tonic, and now these vocalizations. You see, mom just sort of looks and continues activity. This happens all the time. So she has that jerk, and and then she makes these funny noises. It clearly lasts less than 15 seconds. And that was the seizure. So how would we characterize that? I guess we can go back. Maybe some people want to speak. Okay, somebody asked a question. Vash, I'll answer your question in a minute. But how do we want to characterize this? Some people want to offer opinions? What kind of a seizure was that? Nobody has an opinion. She has a quick jerk, and then she relaxes and she makes these vocalizations. So could this be a kind of a myoclonic? It's a bit long. It's probably a variant of a tonic seizure, which has tonic extension, but it's just for a second or less than a second. And then she's spaced out. And I'll show you some other things shortly. But it has that look like it could be a tonic seizure, a variant of a tonic seizure. And then somebody just asked the question, for case 1, can I explain the differentiation between right versus left frontal? To go back, let me come to that after this case, okay? Because I don't want to lose track of where we are. This is her interictal EEG, this girl's interictal EEG. So what do you see? So here, this is a coronal chain from CZ to C4 to C4 to T2 to T1. So sort of right over left. And then here we have a right temporal chain below the EKG initially, then a prominent left temporal chain and a couple of parasagials. So what does this EEG show? The choice is 3 Hz generalized spike wave, focal left frontal spikes, artifact, focal left hemisphere paroxysmal fast poly spikes, or generalized paroxysmal fast. Hopefully I'm moving this out of your way too, so you can, it's not blocking your view of the EEG to answer. So we don't have too many people voting. And I will say that this is one of the more difficult EEGs that you'll see. '23, '24. I don't know how many residents and how many fellows we have on this. So fellows, you should all vote. Okay, so this is what we had so far. We had 3 people out of 35 say 3 Hz generalized spike wave. I think we can look and see there is no, it's not exactly generalized spike wave. It's certainly not 3 Hz. You don't see repetitive spikes repeating at 3 Hz. We can rule that out. Focal left frontal spikes. Well, it looks pretty broad, very widely distributed in the hemisphere, and maybe even uglier over the temporal than the parasagittal. Artifact, no. And some people said 43% focal left hemisphere paroxysmal fast, and then 49%, about half, said generalized paroxysmal fast. So this is actually tricky. You know, you could legitimately say it's quite asymmetric. It's much more prominent over the left side than the right. It's more of a focal paroxysmal fast with volume conduction. That's probably the right answer. You know, if the person did not have temporal lobe encephalomalacia, might this have been a generalized paroxysmal fast? It might have been. But this is likely, more likely, a focal paroxysmal fast. You really have much more of a discharge over the left than the right. And probably you have some volume conduction and also, which I can't show you here, but in measuring it, it actually leads on the left side slightly before on the right by, I don't know, 10 milliseconds or so, or 20 milliseconds. So that's actually callosal conduction from the left to the right. And again, if I was in my EEG program or I had thought of making a second slide, spacing it out, you could more easily see that it starts first on the left, and then you see it on the right some milliseconds later. So this is a focal paroxysmal fast. This is another interictal EEG page of hers, just showing more. Again, you've got these poly spikes. This is the left side down here over right. There's clearly sometimes you have more on the right and other times not. But again, you can see that it's really a lateralized castor. You've got focal spikes and sharp waves, or lateralized spikes and sharp waves, and lateralized paroxysmal fast or polyspike burst. And what's paroxysmal fast? It's a long polyspike burst, that's all. So here's her rectal EEG. Immediately before the seizure, you see she has a big spike over the left temporal region, but it's prominent parasagittal spread. But it looks like a prominent mid-temporal spike and wave, prominent spread. And then here's her jerk. She gets that jerk and stiffening. And then you've got muscle artifact, and you've got some fast activity here. Really on the left, not on the right, and then muscle artifact. And as the page goes along, it's largely obscured by muscle artifact. You can see the whole thing lasts 11 or 12 seconds, and then it ends with this giant slow wave. Oops, I accidentally clicked. It ends with this big slow wave and slows down, and then boom, instantly, these left hemispheric temporal max sharp waves and spikes resume. Good case. For us, not for her. So, is this a generalized seizure of idiopathic generalized epilepsy? This is another poll for you to answer. A focal seizure of left hemisphere onset, a focal seizure, you're not sure what the localization is, or lateralization, I should say, not even that. Generalized seizure of symptomatic generalized epilepsy, or is it a psychogenic seizure? And this is sort of a trick question. It's not as tricky as that earlier one where I had Lapata syndrome as one of the diagnostic categories. If you try to look it up, you won't find that. I just made that up. I was curious to see if anybody would click it. Okay, we have 30 people, 31, 33. I'm going to give you 3 more seconds and I'll end the polling so we can keep going. So we have, we have one person vote for generalized seizure of idiopathic generalized epilepsy. Again, it's not that generalized spike wave that we saw in our first case that builds up to that frontal 10 hertz alpha. It's not that. Focal seizure, unclear localization, 2 people thought that. Then we have focal seizure, left hemisphere onset. And I guess that's probably right. I didn't word the question so well. You could argue maybe the localization is not unclear. Or is it a generalized seizure of symptomatic generalized epilepsy? You know, arguably it's one of these two, right? Maybe it's a focal seizure coming from the left, from that left hemisphere, or unclear localization within that hemisphere, or is it really a generalized seizure? But because she has underlying damage, you don't see the full EEG expression in that side on the right side because she's got an encephalomalacia, and what you're seeing is good spikes where the brain is left. And I think the answer is not so clear. It's really not entirely clear what we have, what you would think what you think would be the best thing. And then, so is further testing needed? So to make a diagnosis, what can we do? Do we need further testing? And I have a question here. What type should we get genetic testing? So does anybody have any thoughts? So somebody asking, can this be atonic head drop and or myoclonic atonic seizure? I think absolutely. Myoclonic atonic seizure might be a very good description from our anonymous attendee in there. And then what other comments have people said? Discharge followed by suppression, and never mind. Okay, I won't mind. But it could be a myoclonic atonic seizure. That's probably, as a classification, that would be a reasonable way to put it, which we think of as being symptomatic generalized epilepsy, not a focal seizure. So one of the complicated things is that people with symptomatic generalized epilepsy can have lots of focal features too. They may have focal spikes, they may have focal discharges, they may have focal lesions in their brain, but it can look like a generalized seizure. And then in deciding to treat it, it's complex. So when little babies are born, for example, with a localized lateralized dysplasia, they may look like they have infantile spasms with both sides going, but if you do a focal operation in those babies with infantile spasms and cut out the dysplasia, their apparent generalized epilepsy goes away, so focal resection does work. So it looks generalized, but it really is focal. So anybody have any thoughts? Do we want any genetic testing in this person? Any thoughts? And I don't see anybody else offering any opinions. Nobody wants to say anything? I mean, you could argue that she was normal until age 2, had encephalitis. The odds of picking up something useful with genetic testing that's diagnostic is going to be very, very low. If this came out of the blue, however, without an obvious insult like encephalitis, then the yield of genetic testing might be 40 or 50% in some of the more recent studies. So there's some advantage to doing it on occasion. Management option. How are we going to treat her? What are we going to recommend? So we have a number of alternatives here, as you can see. We can continue present therapy, no new treatment. We can offer a new medicine, and if so, I'd ask you which one. We can consider surgery. We can consider intracranial EEG. We could do if we do surgery, we could do a calosotomy. We could do a right temporal lobe resection of the encephalomalacia. Maybe responsive neurostimulation, put an RNS device in, or maybe do we do deep brain stimulation? How are we going to handle this person? So 18 of you have offered opinions, now 22. Let's jump up a few more seconds. We're going to end this very shortly. So 40 of you have offered opinions, 41. I'm going to end in 2 seconds. Last chance. No. Okay. So 43 people offered opinions, and no new treatment. Everybody wants to do something. I think that's reasonable. She's crashing to the ground a lot. There's no reason for us to give up. 3 people, 7% said, let's try another drug. What would you use that she hasn't already had? There isn't very much. Cenobamate is coming out next week. On Monday, Cenobamate's hitting the stores. It looks remarkably effective for focal epilepsy. It's not been tried in this kind of epilepsy. Will people try it in this kind of epilepsy? Perhaps some will. I can't advocate for it because there are no studies, but I think in practice, a lot of people may decide to give that a try. But we don't know the benefits in this case. 22, half of you want to put intracranial EEG to localize a lesion for resection. And what are the odds of this person with an IQ of 54 with widespread spikes like this having a well-localized intracranial EEG with SEEG? And I think I'll tell you the answer to that question. The odds of that are about, probably under 10%. It's going to be a very low yield procedure. Very low yield. Some people said, 4 people out of 43 said, try right temporal lobe resection, get rid of the encephalomalacic lesion. I think that's not unreasonable. You could say she's got an obvious structural lesion. If it's analogous, you could go for it. The argument would be that she's really got diffuse multifocal brain damage, else she wouldn't have an IQ like that. And her spikes are much wider spread through the hemisphere. So the likelihood of that operation helping, I think, is going to be relatively low. Arguably, the morbidity of a temporal lobe resection is the same as the morbidity of SEEG. If I'd rather try a therapeutic than a diagnostic procedure that doesn't have a huge chance of working. Below that, we have 13 people, 30% said anterior calosotomy. And certainly based on her behavior, abrupt myoclonic atonic pattern, calosotomy is the operation that we know works in these people. She has a seizure type, and the basic rule is if they stiffen and fall, calosotomy helps about 70% of people. So I think calosotomy is probably the best surgical option, but it's palliative, not curative. In our series at Jefferson, about 10% of patients, or 11%, are seizure-free for extended periods of time after calosotomy. I don't know why. We think of it as palliative and tell them palliative. We had responsive neurostimulation for 2 people. Ideally, you'd have a reasonably well localized focus. The same reason I would not favor an SEEG, I wouldn't do this. Just the odds of finding a well localized focus are going to be very, very small. So you're subjecting your operation for no good reason. And then 5 people wanted deep brain stimulation. The US indication for deep brain stimulation right now is for focal epilepsy, but people have applied it obviously in generalized epilepsy in the past. And while the Medtronic is approved, was tested for anterior nucleus of the thalamus, people are now starting to do studies for central median as well. And I think that too is a palliative procedure that is not unreasonable to consider. I think the highest yield is going to be with calcisotomy by far. That has, again, in our hands, 70% of people have a huge reduction of seizures, at least a greater than 80% reduction in seizure frequency. And in her case, since she's crashing to the ground potentially multiple times per day, an 80% or greater reduction, and many do much better than that, is her best chance. But it's also the biggest operation and the riskiest of them. You could argue deep brain stimulation is a bit easier to do. Again, a right temporal lobe resection is pretty benign in the hands of an experienced surgeon. The risks of permanent serious morbidity are under 1%. You could give that a shot, but I wouldn't be terribly optimistic. You probably have to do a much broader excision to get some benefit from that. So thoughts and comments from anybody and everybody? Okay. So Dr. Shah had just posted a question earlier for case 1. There's 2 videos I showed you. I guess it was really case 2. How to differentiate between right and left frontal. If you have asymmetric tonic posturing, that's the way to do it. So if you have asymmetric tonic posturing of one side, good chance that the focus is contralateral. That would be the best way to do it. Automatic speech is not terribly helpful, and they can stop talking in either case. Okay, well, it is 3 o'clock. We will end. I hope this was helpful to everyone. I want to thank you for attending.